So, I think it's effective. We know it works. We know it works in different populations. We know it works in different settings, but how do we get it, right? And we know that, of all those potentially eligible for PrEP among African Americans, only 11% are on it. Of those eligible among Hispanics, only 20% are on it. And of whites who are eligible, about 78% are on it. So right here, we have a disparities problem, and we know all about disparities in HIV. And those absolutely must be addressed and can be addressed also within implementation science. The other gap is kind of an infrastructure gap, both in the real world and in the study of it. So just as an example of kind of the gap in the study of it, we did a scoping review and published that a couple of years ago. We looked at all NIH-funded studies from 2013 to 2018. They had to be studying, it was something about HIV, and it wasn't, like basic science. It was, either an intervention or efficacy or effectiveness trial. So it had to, they had to measure an HIV outcome. And then we looked at NIH definition of implementation research and implementation preparation research, which I just described to you. And that is the study of the effectiveness of strategies. So we identified 594 HIV-related studies. Again, this is just funded by NIH. And, a little under half of those were implementation research related. But if we use NIH's term, and that is that you're seriously studying if an implementation strategy works, only 18% of all the HIV-related studies were truly kind of implementation research. So at the time when we did this, implementation research was really new in HIV. No problem. We're really great at efficacy and effectiveness studies. And because of that, we have really good interventions. Now we have kind of an implementation challenge. My keys sometimes work and sometimes don't. So I want to kind of, I've given you all the definition, I've given you kind of the jargon-free definition, but please, if you don't know about this, it takes some time to wrap your head around it. And if you do know it, you realize that repetition's not bad, at least in my case. So hopefully I'm not really going over everything, but I want to provide kind of another characterization of implementation science and really stress kind of how it's different and why it's different from what we are typically familiar with. So it has its own set of assumptions and foci. In efficacy studies, you control the context. So you know if the intervention itself works. In implementations, and context is a nuisance. Well, in implementation science, context is everything, and you actually want to know how things work within specific real-world context. It is not something that can happen in a lab in a petri dish with just 5 people and 3 stellar sites. No, you just cannot work without partners. If you're in the real world, you're automatically with partners, and if you really want to know if something works, you're not going to do it without partners. Because they're the ones who really have the knowledge on the ground that you need to study this. Implementation science outcomes are different than traditional efficacy and effectiveness studies. So for instance, anything we do in HIV, we want to know if we decreased infections, and we want to know if people are virally suppressed. Those are health outcomes. And they tell us that if we implemented that intervention perfectly identical to sort of the controlled environment where it was tested, we're going to get the same results. But that we already know it works. So now what we're interested in testing is how well it worked in the environment where it's being implemented, and are we able to reach the people that we intend to reach? So very different outcomes, and sometimes, you know, the HIV cascade has become our mantra, but we need to start thinking about adding implementation outcomes to that cascade. You always start with you usually start with an evidence-based thing that needs to be implemented. So we go back to the thing, you've got the intervention, and now the work begins. And it has a set of specific frameworks, methods, and strategies, which I will talk about in a minute. So just to highlight the emphasis, and again, we like to kind of focus on the effectiveness because we think that's what the field has really done so well and is very aware of versus implementation. So in effectiveness trials, you're studying the intervention and you're looking at it, you're controlling all variables to know whether the intervention works and actually impacted health. Oftentimes, the intervention, you're studying it with a system to support adoption and delivery with fidelity, but it's in the background. That's not what you're studying. In implementation research, you now know it works, so the intervention is in the background, and now you have to look at the system to support, adopt, and deliver with fidelity. So the focus is now not on evaluating health outcomes, but on evaluating the quality, quantity, and speed of delivery in a real world context. So again, this is where context is everything. We are rolling up our sleeves and getting messy because we are in the world of reality. So I mentioned there's all these theories, models, and frameworks, and there is a method to its madness and a reason for each one. So there's kind of three overarching kind of goals of these theories, frameworks, and methods. One is to describe and or guide the process of translating research into practice. So we're translating an intervention that we know works into practice. And those are called EPIS models. Those are called process models. And some of you might be familiar with these. That is EPIS, PRISM, and knowledge to action frameworks. They're determinate frameworks, and those are intended to understand the factors explaining what influences implementation outcomes. And we have determinate frameworks, classic theories, and implementation theories within that category. And then we're interested in evaluating implementation, and this is somewhat related to the standard evaluation that many of you might be familiar with. And they're evaluation frameworks, and oftentimes have measures that you probably are already familiar with and could translate to. And those frameworks are called REAIM, PROCEED, and others. So I want to make mention for a minute that there are many frameworks, and as implementation science is a science, it's always trying to understand what new theories and focus and frameworks might we need to identify a specific problem. And as we mentioned, health equity is front and center of the work that we do in HIV. We know we aren't there, we're far from it. And we might need a framework to do it. And what health equity implementation frameworks are doing, it's based on an original one, but it is decided to really focus much more closely on the recipient, that is the patient, the clinical encounter it has with the provider that may or may not be meeting its needs so that they can stay in care, for example. Kind of the social context in which these individuals might be living in, so that they can be understood as you're getting regular care with them. And this is happening at different levels, but really focusing on the clinical encounter and that relationship within a care system. with the patient whose ultimate health we want to improve through the intervention is really key. So, I think it's something really important for you all to think about as you're selecting these frameworks. And, as I mentioned, there's 5 different types of theories, models, and frameworks, and within them, there are a lot of different types. So I'm going to be describing the most common ones, and each one might be tailored to kind of what it is that you want to do exactly, and this health equity framework is an example of that. So kind of what's the roadmap in implementation science? And really, I've got all these methods and frameworks, what do I do? Well, first you want to kind of plan for implementation. And that has, we'll discuss frameworks for that. Then as you're planning for it, the first thing you're going to want to do is, what problems am I going to encounter? And what do I have that's going to facilitate implementation? So that's identification of barriers and facilitators. For the problems that you have, or the strengths that you have, if you think about the problem, you're going to say, okay, I need some implementation strategies so that I can address the barriers that I know I'm going to encounter. And I'll describe those in a bit. So you want to, at some point, you're going to select and tailor strategies to address as many barriers as you can. And some of your strategies might be things that are facilitators. So for instance, if you have in your organization a really strong learning environment where every 2 weeks you get together to read an article or to discuss something, and there's a learning environment, then maybe training for a new intervention might not be that hard because that kind of infrastructure is already there. I tend to be barriers based, but facilitators are really key. And if you recognize them, it's, you've got, a head run. And then you want to, measure the different outcomes. So that's kind of the pathway, and really that's it, although there's a lot to choose from. So that could be EPIS, ERIC has a strategy, CFAR helps you identify the barriers and facilitators, and REAIM can be one of your outcomes. That's just one example. So one thing I want to stress is that, if you're a CBO, you might be, if you're somebody who works in a real world setting, you might say, oh yeah, I've worked with great researchers who come and, want to study something. And I find that, things work really well when they have a really good understanding about how we work. A researcher might really, recognize that there's a lot of things they need to know about this context that they're studying so they can prepare for it and understand it. So you really need to start this pathway with community engagement, and what you're studying really should be of importance to the community partners that you're working with. If not, it does take up time, and it might not be worth their time if it's not addressing their priorities, their needs, and something that they'll be able to get at the end of the study. And again, the foundations are in principles and health equity, which I think we really do get in the world of HIV. So another way of thinking of this pathway is something called the implementation research logic model. It's a similar pathway. You see the same elements, right? You see you've got your intervention, you have your barriers and facilitators, strategies and outcomes. But in this structure, you really want to, you start aligning and relating how these are the barriers, these are the strategies to address them, and these are the outcomes I expect to achieve from them. So the implementation research logic model is a really nice way to kind of start thinking if you're going to conduct implementation research, if you're a researcher. The pathway, is higher level and similar to this, but the pathway can be very helpful for an agency who's implementing something new without really even being part of a research project. So there really is a lot of benefit to some of these tools and concepts that people can use, even though that agencies can use, even if they're not conducting true implementation research. So at this point, I'm sorry, you're probably feeling like this. Well, welcome to implementation science. It's a fire hose of information. So I'm gonna try to make it a little bit easier, and I'm gonna start using an example to illustrate these principles. I just want to make sure, do we have any questions thus far? Any clarifying questions or anything of any sort?
There's just one question in the chat from Tanya. Will we be provided with the slides after the webinar?
Yes, you will.
No other questions as yet.
Okay, thanks, Abby. So just to, I'll start with an example and try to ground you all again. I do hope that everybody knows about PrEP. So pre-exposure prophylaxis is a pill that you can take that is very similar, based on the antiretroviral drugs that people take when they have HIV. But if you take a lower dose, certain dose of certain medication of those for people with HIV, you can prevent the virus from kind of living and growing. So highly effective, about 90%, 90 to 95% effective. In some populations, about 70 to 75, and these numbers might have gotten better among injection drug users. So highly effective. PrEP implementation, we've now been in this for about 8 to 10 years. It can happen at all different levels, right? At the national level, it can happen, with partnerships between national funders, state and local public health departments, national associations, advocacy groups, researchers, policy experts. Like those are all, it can take place in that arena. Locally, it can be city or statewide. It can happen city or statewide through public health departments, community advocates, and provider partnerships. Or it can be clinic-based, really zooming in. And at the clinic level, you could have an STD clinic, you could be a family planning clinic, provide HIV primary care, FQHC. So there's various levels within this kind of public health system in which you might want to implement PrEP. At these different levels and at these different systems, you're going to implement it in different ways. There's different things that you have to do. So the scenario that I'm giving you all is just based on an amazing study. And can you give me a time check, Abby or Amanda? Like it might be easier if you give me your hand because I've got lots of things going on the screen. So this is a Dawn Smith, may she rest in peace, a fabulous woman from CDC who is really the PrEP champion and really kind of, single-handedly doing marvelous things to get PrEP scaled up and used after we knew it was efficacious. So she and members of NATO, Gretchen Weiss, did a survey of 500 local health departments in 2015. That was, the census of local health departments is, I don't know, up to 4,000. So this was about 10% of local health departments, a really decent sample size, random. And about half of them responded. And of those who responded, 38% said they were currently engaged in PrEP implementation, and 81% of them had an STD clinic. STD clinics, perfect place to do PrEP. You have negatives and positives. You can provide STD treatment and refer to care for those who are positive. And for negative, with PrEP, now you can actually offer them something. The use of this was higher among local health departments serving large populations. Not surprising, so harder to get PrEP maybe in rural areas and having it be implemented in rural areas. And about 45% planned on expanding PrEP in the near future. So that means that 62% were not currently engaged in PrEP implementation, and 60% of them had an STD clinic. So again, really, not capitalizing on a place that serves a really important population. So this is the backdrop, right? And then the beauty of the survey is they ask them, what are you doing? What are you having problems with? What are the challenges in implementing PrEP? And what things have you done to implement that successfully? So I will use this survey to kind of illustrate the different frameworks. So if you're planning for implementation, this is really nice because when you're planning, this is a process framework. It's called EPIS, and it stands for Exploration, Preparation, Implementation, and Sustainment. And it recognizes that that is a really natural way in which we implement things, right? You start with, oh my, I'm identifying a lot of high-risk negatives in my STD clinic or STI clinic, and we need something for them. You know, our prevention programs aren't that effective anymore. We need something else. Ah, there's PrEP. There's this pill that we can recommend and help them take and maybe provide in our setting. Preparation is kind of that part where you're like, okay, what problems might we encounter? How can we do that? How can we overcome them? Implementation, you know, you've got a plan, you're kind of tweaking as you go, but you've kind of full-fledged have everybody doing it. And then you're sustaining this. It worked, everybody gets it, but sustainment also takes some time and work. So the framework recognizes that for each one of those steps, there's a lot of things that can happen, go wrong, and help and support what you're doing. So it's called a process framework, and it's trying to understand how this works. So, for instance, in the clinic survey, we see that for those that were currently engaged in PrEP implementation, what were they doing? They had, clearly they were past the exploration. They knew they needed PrEP, and they were either referring high-risk individuals to PrEP. So recognizing perhaps not able to do it, but referring them. Conducting community education and outreach. And we noticed that very few were delivering PrEP at a health department clinic. So, an area to explore and understand if we're interested in scaling up PrEP in all STD clinics, for instance. At a national level, that would be what we want to do. So, one way to think about this EPIS framework is, from that survey, we discovered that among the 62 health departments that weren't implementing PrEP, 41% were currently not interested in PrEP. So they weren't even in the exploration phase where they thought this is something they needed to do. 46% of them were contemplating it, but they need kind of some support and some nudging to see the value in doing this. And 13%, they were interested in maybe implementing in the future. So some education needing to happen on that end. And among those who were implementing, the 38 who were implementing, that's a place where you can do kind of data monitoring and look at metrics and feedback to improve delivery and sustainment of PrEP. So determinants, right? You're ready to do it, you want to do it, and the determinants, as I mentioned, they really tell you what is going to make the thing work or fail. And you also probably want to understand if you have an implementation strategy, why does that work or fail? And as I mentioned, these can be positive or negative. They're either facilitator or variables. So the most common of the frameworks is called the Consolidated Framework for Implementation Research, and it's known as CFAR. There's a lot of support on that and a lot of tools. And CFAR has 5 domains. And if you think of really kind of, I now see the world through CFAR, but it really does kind of work that way, right? If you're in a work environment and you're trying to get something new in, there's various places where that can happen, right? Where it's going to be supported or really kind of be hindered. And that has to do the outer setting, like, do you have funding? Does the world at large even think it's something that they need? Within the inner setting, lots happening within the inner setting. If you think of your clinic, there's lots of processes and people involved in those processes that might get in the way. The characteristics of individuals. So, you could be, if you think of the days of, highly stigmatized 1985 and HIV, the characteristics of the care and the providers was really important, right? They didn't want to treat this population. They didn't believe in art. They maybe wanted to use, didn't want to use the combination therapy. So individuals who provide care matter. What they know and what they believe really can affect your implementation. And then the characteristics of the intervention itself. So maybe some of you have heard, PrEP is kind of easy to take, but there could be, an intervention that is just, time consuming for the system, for the client. People might be hesitant about its evidence. There might be misgivings about it. So just kind of intrinsic characteristics of the intervention. And then there's the process, like, are you planning well? Are you engaging? Or is everything happening the way it should be? And a really powerful thing about CFAR, and I tell you, CFAR is pretty astonishing. I have the link here to, and the resource to CFAR. There's a new version of it, but the old version had all the 5 domains. And within the domains, these constructs, which are these bullets. And for each one of those, there's kind of a description of what that might be. And as somebody who worked at the health department, one day I went through all 78 items on this list. And I really was able to recognize them. Like, it is so comprehensive that if you go through all of CFAR when you're trying to implement something, you'll probably know that all that could go wrong. You might not be able to fix it all, but this is really making you think very clearly about what could go wrong. So very comprehensive. And you can use it in different ways. You can use it during pre-implementation to help you plan and identify strategies. You can use it during implementation and really use it to make sure that you're making the progress that you need to in your implementation. Or you can use it once you're done and apply CFAR and try to understand why things went wrong. So lots of different ways to use it, all very, very powerful. So if we look at the health department example, as part of the survey, we have those who are engaged in PrEP and not engaged. And among those who were engaged, they were unsure about what the health department could do or if it even should support PrEP. So they'd started the process, they're engaged, so they know more about what's happening, and they don't know how to, they're not quite sure about what the role of the health department should be. So not a good understanding of whether this is something worthwhile and they should change kind of the way they think of their process. An outer setting, which you'll probably you'll recognize and know, was concern about financial access to PrEP. So in 2015, there wasn't much funding for PrEP. It wasn't even clear if Medicaid or Medicaid would pay for it. There was a lot of uncertainty, and only a few studies would really help pay for that. And not all healthcare providers believed in PrEP yet, and they weren't ready to provide it. So 46% of those who engaged, noticed that there was a lack of healthcare providers willing to do this. Within the inner context,
sorry.
Yes.
I was trying to get your attention. We have about 5 minutes left.
Okay. So again, this kind of gives you a sense of, the types of inner setting, kind of the determinants that you have. And then you're going to want to identify strategies. And there's a wonderful tool called ERIC. it's a work in progress, but again, it's a really comprehensive list of strategies that you might be able to take to address those determinants. Here's just one example of a strategy. They were having trouble identifying people, getting care to people with PrEP. So one of the strategies was, we'll never be able to provide it, but we can get a really good referral going. And what do we need to do to get that referral going? So a number of implementation strategies, given that something might not work. I'll skip this. So just implementation outcomes, just really quickly, and we're almost over, but they are the effects of deliberate and purposive action, implementation strategies to implement new treatments, practice, and real-world settings. So what effect did the implementation have? Not what effect did the intervention have, but what effect did the implementation have? So just one of the most common frameworks is the REAIM framework, and it looks at reach. There is a level of effectiveness that is going to tell you if there was a health outcome. Did people adopt it? Did they implement it? And were they able to maintain it? And we have created, here's an example, and you will get a copy of these slides, but I have examples here of how in that STD clinic, you might be able to, what would be the types of implementation outcomes that you want. I'll probably highlight, for instance, adoption is a really important one. Like, do all the providers who give you PrEP really are ready to do it? So you're looking at, for instance, what is the intention to prescribe PrEP, the uptake and utilization of PrEP in STD clinics. So you would just closely look at your providers and see if they talk to the client about it, if they prescribed PrEP, et cetera. So here's just an example of, with that STD clinic example, you then kind of identify very clearly what your barriers are. You identify what implementation strategies are going to help identify that barrier and what outcomes you think they're going to help you reach. And really kind of matching this and having it in such a clear way is going to really facilitate how you're going to design your study if what you really want to do is kind of do an implementation research and identify the effectiveness of your strategies. Amanda, I have a lot more, and I'm done because I know there's only 5 minutes left, but in the presentation, I just want to say I have like 5 pages of resources, kind of all the footnotes and things from what I presented. And if nothing else, I would recommend that you all take a look at impsci.northwestern.edu. It is a website that that Northwestern has put together, ISKI has put together, and there's tons of resources there. And we actually now have a tool that where you can try to develop your implementation research model, and it's interactive and click and go. So it's its first version, but please use it and give us feedback as you were doing so. Okay, I am done.
Thank you so much. That was fantastic. That's virtual round of applause. Thank you. And yes, that website is my go-to for everything. And I also just want to remind everyone that we did provide some reading materials and some video link as well. If you want to get more information, just kind of about the big picture, 10,000 foot overview of implementation science. Are there any questions for Nanette?
I just have one. Thanks. That was a great presentation. And I think my big question is, do you find that funders are receptive to, you talked a lot about planning and how important planning is. Do you write an aim about planning into most of your projects? Is it possible to get that planning funded? Because I agree it's super important and time consuming.
Yeah, that's a great question, Anne. I think funding is getting there. Funders are getting there. I'm really encouraged with sort of what NIAID is doing and NIMH nowadays. I don't know. You could have a level of planning. You could use an implementation strategy that's actually maybe helping you develop what it is, the implementation that you want to do, because they recognize that partnerships and working through those partnerships is important. Mm-hmm. I think they'll also like to see that you've done already some of that work, that your relationship with the partnership is strong, that you already have some relationship and knowledge of that person, of your collaborators. But I have seen that there is a certain amount of kind of prepping and gearing up for the intervention. Certainly, identifying barriers and facilitators, which I would say is some level of planning and groundwork before you can get started.
Okay. All right. Thank you.
I would add also, at least in my experience, the 2 grants that I have that have implementation science in them also, that first aim is generally like we're using the CFAR model to identify facilitators and barriers. I don't know if that's what you mean by planning, Anne, but kind of figuring out, what's the landscape before you jump in and actually try to implement. I think, Abby, you had your hand up.
Yeah, I just wanted to share, I didn't share this in the beginning, but, this session is really 101. But our hope is that, as participants, you would be bringing some challenges or successes that you've experienced in implementation science, so that this could be a robust space for discussion. Nanette, as I was looking at this, I was thinking about when I was doing HIV prevention work and back in a long time ago, and identifying interventions that were evidence-based and implementing it in our organization and finding so many gaps in terms of how do you take this intervention that's been proven to work, and shown to work on the CDC website, and then apply it to this specific context and group, but not having a research partner to help us think through how much adaptation removes the efficacy and is no longer even evidence-based, right? So I think for me, it's those sorts of questions. I think for something like PrEP, PrEP is PrEP. You take it 1 pill a day and it's efficacious. But when it comes to stuff like curricula, something that focuses on disclosure, implementing it in a community where there's HIV criminalization, like walking through those tools is something that I'm really excited to do more of as this series goes, so I could learn more about how much is too much adaptation and when is it no longer actually implementation of the evidence-based intervention. You know what I'm saying? Anyway. Yeah.
That, I totally know what you're saying, and that is really key. And I think just adaptation is a session in and of itself. Yeah, it's crucial. Yeah.
Nanette, just one more question, then I think we should wrap up because it's, after 7. But you made a point of, and this is something that I get asked quite a bit about, so you're measuring, when you're looking at outcomes, you're measuring the effect of the implementation and not the intervention. But for something like PrEP, right, and you showed us that I guess it was a re-aim or in your logic model, right? Like you're still measuring uptake, but you're not, it's the distinction that you're not measuring like its efficacy in terms of prevention. Is that what you mean by that?
Yeah, so there is re-aim does have efficacy. So it does recognize a certain level of it does recognize the importance of health outcome. But it's, 1 of 5. And it might not be pristine, like it's not, it's hard to measure whether you prevented an infection, right? Whether you averted an infection. It is probably, it could say that nobody has seroconverted, but they're not controlling, groups to make sure that, you did indeed avert infections and try to get a measure like you would in an efficacy study. because all of it's happening in the real world. Good implementation science should be using existing data as opposed to collecting a whole bunch of new data. That would be a very high burden. So I think you could get some measures, but not true efficacy measures.
Thank you for clarifying. Well, we'll have to have you back for another hour because we didn't finish. You didn't get a chance to finish. There's so much to learn, and we really appreciate you taking the time to share all of this knowledge with us. And we look forward to continuing the series. And I just want to thank everyone for their time and attention. And again, to thank you, Nanette, for your expertise and sharing it with us.
Thank you all. And Amanda, please share my email with them. I'm happy to route them to a lot of other stuff that we have. So happy to stay in touch and help in other ways.
And I just wanted to add that if you had any burning questions from this session, please write them down, because the next session, we're going to build on this.